and dear to near and dear to every perinatologist because we deal with it so much, and that's hypertension during pregnancy. But we're going to focus on management of hypertension postpartum in our pregnant patients, and touch a little bit on future risk and new measurements that we're using for the diagnosis and classification of hypertension. So I think the key to checking the blood pressure is just to making sure that it's as accurate as can be. And the best way to do that is to check the blood pressure with the patient at rest. Best to have them sitting or lying for 5 minutes or so, and you'll get the best of the most accurate reading. I put be aggressive from the standpoint that postpartum, we don't have the fetus in utero to be concerned about dropping blood pressure too much. And if you have a patient with mild hypertension, my personal practice is if I think about starting a blood pressure medicine in a patient, I start the blood pressure medicine. And I think that we're going to find in the future that may prevent those patients from having postpartum admissions for hypertensive workup and preeclampsia. We're keeping data on that, and we'll see how that goes. But I really am aggressive at starting blood pressure medicine in the postpartum period before patient goes home. If they have borderline hypertension or hypertension, whether it be gestational or preeclampsia, it's very important for us to follow those patients up more quickly than that 6-week postpartum check. And I say 4 to 7 days after discharge, that patient needs to be evaluated. I give them strict instructions and precautions for preeclamptic symptoms as well, and have them call in or come in if there's any issue to labor and delivery after discharge. Next slide. So one of the considerations we have to think about is what do we treat moms with if they're breastfeeding? And the two medications that we utilize most often in pregnancy are very safe in breastfeeding moms, and those are the calcium channel blockers and beta blockers. The calcium channel blocker that we most often use is nifedipine because it works so well. It brings the blood pressure down quickly and it's very potent. Amlodipine is fine. It's just a milder calcium channel blocker. I don't use it as much, but I certainly do, particularly in patients who have been on it before. Labetalol is a combination alpha beta blocker. The beta blockade is nonspecific, and it's about 5 to 10 times greater than the alpha blockade. It's a very good blood pressure medicine. The downside for labetalol is it's 2 to 3 times a day. So the reliance of a patient taking it regularly is not as great as it is with nifedipine, but it's a very good blood pressure medicine. The other thing that I like about labetalol are the side effects tend to be a little bit less, specifically dizziness and headaches. The older medicines that certainly can still be used if the others haven't worked well or patients have been on methyl-dopa or clonidine, they're perfectly fine. The fluid pills, the diuretics, HCTZ and Lasix. HCTZ, many people were on them pre-pregnancy and want to restart them. I think they're fine to use. I think you just have to understand that they can decrease the intravascular volume and can impair the breast milk production from a volume standpoint. So patients who are on diuretics just really need to understand that they need to have an increased fluid intake. The things that we need to try to avoid are the ACE inhibitors and the ARBs. And the reason for that, we know during pregnancy we shouldn't have moms on them because they can impair fetal renal function. They cross the placenta easily and can lead to dysplastic kidneys and abnormal renal development. In breast milk, the ACE inhibitors don't cross as well as they do across the placenta, but there is about a 10 to 20% crossover into the breast milk. And there have been theoretical concerns about hypotension in the neonate from getting those ACE inhibitors into the bloodstream, particularly in the first 2 to 4 weeks of life. So we prefer not to use the ACE inhibitors. If one of those is really needed in cardiology, for instance, really wants them to be on one, and it's enalapril is the drug that has the least crossover to breast milk. So if you have to choose one in a breastfeeding mom, that's probably the best one. Next slide. So I liken gestational hypertension and preeclampsia to gestational diabetes. It gives us a select population that we can do some interventions in that may make a difference in their life later on. And that is, we need to focus on weight loss if the patient's overweight, really alter their diet to a cardiovascular friendly diet with salt restriction, which really does play a role in hypertensive disease. Become more physically active. Some exercise regimen is extraordinarily helpful in these patients. And then alcohol moderation and obviously tobacco use, stop tobacco use if the person does that. But alcohol moderation in men, the suggestion is 2 drinks or less daily, and in women, 1 drink a day or less, preferably none, but if they're going to have alcohol, to moderate that. Next slide. So preeclampsia has long been associated with chronic hypertension and renal disease. And over the last few years, there's been the tie with preeclampsia during the pregnancy to later cardiovascular disease. And we'll touch on that. Next slide. So the newer terminology is the maternal placental syndrome. And we know that with preeclampsia, that this is associated with abnormal placentation. The spiral arterioles just don't develop as they normally would in a normal pregnancy, and it's associated with both gestational hypertension and preeclampsia. And this has been kind of labeled the placental syndrome to include fetal growth restriction, because we know similar things are going on with the placenta in babies who truly have growth restriction as well. So the maternal placental syndrome really includes all 3 of these diagnoses. Next slide. So placental syndromes complicate 10 to 15% of the pregnancies and are a leading cause of maternal and child morbidity. And we know that because we see this every day. They're pretty self-limited, but again, we're learning more and more of the association with increased risk of cardiovascular disease later in life in patients who have these issues. Next slide. And with preeclampsia, we have learned that there's a 4 to 6-fold increased incidence of chronic hypertension. And there's at least a 2-fold increase in heart disease and cerebrovascular accidents or stroke. The earlier the development of the complications in pregnancy, i.e., the earlier the preeclampsia, the earlier the IUGR, and the more severe the hypertension, the more severe the IUGR, the higher the risk of the long-term cardiovascular effects. And gestational hypertension and fetal growth restriction act very similarly as does preeclampsia in regards to that associated risk. So all three of those arms, so to speak, of the maternal placental syndrome have a major effect later in life. Next slide. So there's a lot of studies being done now on looking at is this a brand new thing, the preeclampsia that happens in pregnancy, or the IUGR that happens in pregnancy in a patient with no risk factors? They're totally healthy, and it's just a de novo issue that develops in pregnancy. Those patients tend to have a little bit lower risk of long-term effects, but there are a group of patients that are likely either be genetics, the family history, the lifestyle, whatever, that puts them at greater risk of cardiovascular disease. It's believed now that those patients are the ones that develop the placental syndromes very early in the pregnancy, and therefore their cardiovascular risk is much higher. And obviously, diabetes risk is tied into that because it's all really based on the same pathophysiology. Next slide. So this is just a graph. I love graphs because it shows you the picture. This just shows the picture of the probability of chronic hypertension long term in patients who have had preeclampsia. And the risk is significant, and it's definitely higher than the general population. Next slide. So again, it helps identify a group of patients that we really need to focus on having in for their yearly exams. If that's an OBGYN, guys, we got to be sure that we're working them up like we're supposed to make sure that they are minimizing their cardiovascular risk. That's doing fasting lipid profiles, doing diabetes screening, watching their BMI, and encouraging lifestyle changes with exercise and diet. Next slide. So blood pressure definitions, I just wanted to touch on this because it's changed a little bit, and this has been out for a while. We talked about this several years ago, actually, on this echo. The American College of Cardiology and the American Heart Association both have adopted these new definitions, with normal blood pressure now really felt to be less than 120 over 80, and they're elevated with anything over that, with stage 1 hypertension being that 130 to 139 over 80 to 89, and stage 2 hypertension has now been moved up to that 140 over 90 or greater. And the highest value in the systolic or diastolic is what gives you the diagnosis. Next slide. So I think we have to think about how to take blood pressures. We got to make sure that we're doing it right. If we're going to use cutoffs like this to define the need for interventions, and errors can be avoided by, number one, having a patient sit quietly before taking their blood pressure. And the recommendation is 5 to 10 minutes if you can have them sitting before you take their blood pressure. Support the limb so that where the cuff is, it's at the heart level, and you got to use the right cuff and deflate the cuff slowly. We got to be careful not to use a single reading to make a clinical diagnosis or define our decision making. And it's very important to decrease those random errors by doing 2 or 3 measures, preferably done on 2 separate occasions. An out of office blood pressure measurement is super helpful, and we use this all the time, and I bet you guys do in your practices as well. Have the home blood pressure monitoring, and we like to calibrate their blood pressure monitors with hours in the office when they come in. Next slide. So the accurate measurement of the blood pressure is essential to stratify the cardiovascular risk and guide the management. Um, Target blood pressure it should be in the non-pregnant patient less than 130 over 80. And if they have a 10% or more 10-year atherosclerotic cardiovascular disease, that's when we start treating patients. Now, if they have a lower risk, if they don't meet that criteria, non-pharmacological interventions are suggested. And that is, again, exercise, diet, modification, and lifestyle. Next slide. And I include this because it's helpful, and these will be on the website, but this is the risk calculator for 10-year atherosclerotic cardiovascular disease risk. You can click on this, plug in the information for your patient, and it will give you the risk. And actually, most people fall into that category, honestly. So we'll be using the 130 over 80 blood pressure reading to list as abnormal and for treatment. I think that was my last slide. Yes, it was. So I will stop